Welcome back to the deep dive. Today we are shifting gears a little bit. We're not just talking about broad concepts. We are putting on the scrubs, walking directly into the exam hall, and we are laser focusing on a scenario that I think keeps MD students up at night.
Yeah, that's for sure. We're talking specifically about the Gujarat University MD anesthesiology exams.
Exactly. And the topic we're tackling today is, well, it's the absolute bread and butter of the specialty, isn't it?
It really is. I mean, this is the one question that if you mess it up, you don't just lose marks. You kind of lose the examiner's respect entirely.
That's a good way to put it.
We are talking about adult cardiopulmonary resuscitation, CPR.
It's incredibly high stakes, not just for the patient, which is, obviously life or death, but for your degree, for your career. We've pulled together a pretty massive stack of sources for this one. We're looking at the heavy hitters. So Miller's Anesthesia, of course, the 10th edition. We've got the ICU Protocols book, the Oxford Handbook of Critical Care.
But you've also done something else, which I think is really useful.
Yeah, we've analyzed the DNB and the university question bank patterns to see what they actually ask. What are the recurring themes?
And so the mission for today is simple. We need to synthesize all of those guidelines, the algorithms, the physiological mechanisms into one comprehensive overview.
Right. So whether you're sitting down to write a 20-mark long answer, or you're scribbling a short note, or maybe you're standing in front of that stern professor for your Viva or an OSCE.
This deep dive is going to arm you with exactly what you need to say, and just as importantly, what not to say.
Okay, so let's set the scene. You're in the exam hall, you turn over the paper, and there it is. Describe the management of adult cardiac arrest. Or maybe you're in the Viva and the examiner just points to a mannequin. Where do we even begin?
You begin with precision. Definitions are everything in an exam. You don't just say CPR is restarting the heart. That's not good enough.
They want the textbook language.
They want the language from Miller. You start by defining cardiac arrest. So what is it? It is the cessation of all cardiac mechanical activity.
And how is that confirmed clinically? Because I feel like in real life it's chaos. But in an exam, they want specific, observable signs.
Strictly speaking, it is confirmed by three things: unresponsiveness, the absence of a detectable pulse, and apnea.
No breathing.
But there is a huge caveat on that breathing part, and this is a common trap: agonal respiration.
The gasping.
The gasping, exactly. That weird fish out of water breathing. It is not effective breathing. It's a brainstem reflex. In the exam, you must state that cardiac arrest is often accompanied by these agonal gasps, and they should not be mistaken for signs of life.
If you miss that distinction, you've already lost a couple of marks, I imagine.
You're on the back foot immediately, yes.
Okay, so we've defined the problem. Now the solution. We all just say CPR, but I've heard some of the older professors prefer the term CPCR.
Yes. Cardiopulmonary cerebral resuscitation. It's a bit of a flex, maybe, but it shows you understand the ultimate goal.
It's not just about the heart.
It's not just about the heart. As Miller points out, the goal isn't just a beating heart. It's the restoration of spontaneous circulation with, and this is the key phrase, intact cerebral function.
Right.
If you get ROSC, return of spontaneous circulation, but the patient is brain dead, you haven't truly succeeded. So your opening statement in a long answer should reflect that dual goal.
So perfusion of the heart to restart it and perfusion of the brain to save the person.
Exactly. That's a very strong opening.
Okay, that is a fantastic way to open a written answer. Now let's talk structure. How do we organize this massive topic? The sources all talk about the chain of survival. Is that just something for lay people, or do we actually use that in an MD exam?
You absolutely use it. In fact, you should probably draw it. It is the framework for your entire answer.
Okay.
The American Heart Association uses the chain of survival to illustrate that success, that survival. It relies on a whole series of time-sensitive actions. And, you have to remember, a chain is only as strong as its weakest link.
So let's break it down then. Let's walk through the links for an adult.
Okay, there are 5 critical links. Link number 1 is early recognition and activation.
So just realizing something's wrong and shouting for help.
Basically, yes. You have to realize the patient has arrested and call for help. In the hospital, this also implies surveillance. Our monitoring systems, our early warning scores, they're meant to catch the deterioration before the arrest actually happens.
Right. Okay, so that's link 1. What's link 2?
Link 2 is early, high-quality CPR. And the emphasis is on both of those words, early and high quality. We're going to get into the metrics of what high quality means in a minute, but the concept here is that you're buying time. You are manually perfusing the vital organs.
Okay. Link 3.
Early defibrillation. For certain rhythms, this is often the single most important deciding factor.
For the shockable ones, like VF.
For ventricular fibrillation or pulseless VT, yes. Every minute of delay in defibrillating those rhythms reduces the chance of survival by about 7 to 10%. It's a massive drop-off.
Wow. Then we get into the stuff that we as anesthesiologists really on.
Right. Link 4 is advanced life support, ALS. This is the drugs, the advanced airways, figuring out the differential diagnosis, all of that.
And the final link.
Link 5, and this is the one people often forget in their answers. It's post-cardiac arrest care.
Right.
The resuscitation doesn't just end when you get a pulse back. In fact, that's when a whole new, really complex phase of critical care physiology begins.
Okay, so if I'm a student, I've defined my terms, I've drawn my chain of survival. Now I need to dive into that first big chunk. Basic life support, BLS. Now, I remember learning ABC back in the day. Airway, breathing, circulation, but that's gone.
Long gone. And that is the absolute core of the exam answer here. The sequence has shifted. It is now CAB.
Circulation, airway, breathing.
Circulation, airway, breathing, compressions first.
Can we talk about why? I mean, oxygen seems pretty crucial, so why would you put the airway second?
It's a great question, and it comes down to physiology. In the first few minutes of a sudden cardiac arrest, what's in the blood?
Oxygen.
The blood is actually still well oxygenated. The lungs have a functional residual capacity that's full of oxygen. The problem isn't a lack of oxygen getting in. The problem is transport. The pump has stopped.
So the priority is moving the oxygen that's already there.
Exactly. Compression circulation take absolute priority because you need to move that existing oxygenated blood to the brain and the heart. If you waste 30, even 40 seconds fumbling with an airway, you've just denied the brain critical perfusion for no good reason.
That makes perfect sense. Okay, so let's talk about the check. You're approaching the patient. You check for responsiveness. They're not responsive. Then comes the pulse check. And I feel like there is a specific exam trap right here.
It's a massive trap. It's the 10-second rule.
10 seconds.
The guidelines are crystal clear. You check for a central, pulse carotid is preferred, femoral is also acceptable, but you do it for no more than 10 seconds.
And what if you're not sure? I mean, let's be honest, in a crisis, your own pulse is pounding in your fingertips. It can be hard to tell.
If you are not sure, or if you cannot feel a definite pulse within those 10 seconds, you start CPR.
No hesitation.
No hesitation. The trap that students fall into in a Viva is they'll say, well, I'll try to find the pulse, and if I can't find the carotid, maybe I'll check the femoral, and maybe I'll get my stethoscope and listen for heart sounds.
And meanwhile, the patient's brain is becoming ischemic.
Exactly. You've just wasted 30 or 40 seconds. You have failed the station. The rule is simple. Doubt equals compressions.
That's a great mantra. Doubt equals compressions. Because it's much safer to do chest compressions on a patient who has a pulse than to not do them on a patient who's in arrest.
Precisely.
Okay. So, speaking of compressions, this is really the meat of the BLS answer. We need numbers here. We all hear push hard, push fast. Let's quantify that.
Correct. Let's break down the metrics because you can bet the examiner will be ticking these off on their sheet. First, rate. The target is 100 to 120 compressions per minute.
Okay. Why the upper limit? Why not 140 or 150? Surely faster means better blood flow?
You would think so, but actually, no. Miller explains this beautifully. If you go too fast, say over on 40, a couple of bad things happen. One, you tend to lose depth. You just can't push as hard when you're going that fast. You start fluttering on the chest.
Right.
But more importantly, physiologically, you drastically shorten diastole.
And diastole is when the heart itself fills with blood.
Correct. And crucially, it's also when the coronary arteries are perfused. The heart muscle gets its own blood supply during the relaxation phase. If you are pumping at 150 times a minute, the heart never gets a chance to relax, the coronaries never fill, and the myocardium remains ischemic.
Wow. So you're essentially trying to save the heart while simultaneously starving it of blood.
That's exactly what's happening. It's a brilliant physiological point to make in a Viva.
So 100 to 120. Got it. What about depth? How deep do we push?
At least 5 centimeters, which is about 2 inches, but not more than 6 centimeters or 2.4 inches. You need to generate enough force to actually squeeze the heart between the sternum and the spine.
Now, is there a theory on how that actually moves blood? I remember reading about a couple of different proposed mechanisms.
Yes, and mentioning this in your answer scores bonus points. It shows you've read beyond the basic algorithm. There are 2 main theories. The cardiac pump theory is the intuitive one. It says you are directly squeezing the ventricles, mechanically ejecting blood.
Like squeezing a ketchup bottle.
Pretty much. The other is the thoracic pump theory. This one suggests that by pushing on the chest, you increase the overall intrathoracic pressure, which forces blood out of the entire thorax and into the systemic circulation. In reality, it's probably a combination of both.
Okay. Now, one thing the ICU protocols book emphasizes very heavily is recoil.
Allow full chest recoil. This is arguably just as important as the compression itself. Do not lean on the chest between compressions.
Why is leaning so bad? What's the mechanism there?
Well, think of the heart as a bellows or a suction pump. For blood to get out, it first has to get in, right?
Right. Venous return.
Venous return depends on creating a negative pressure inside the chest during that recoil phase. If you're leaning on the chest, you maintain a positive intrathoracic pressure. You prevent blood from returning to the chest from the vena cava. So if the heart doesn't fill, you have nothing to pump out on the next compression.
It's like trying to squeeze a sponge, but never letting it expand to soak up more water first.
That is a perfect analogy. And finally, on compressions, you have to minimize interruptions. The goal is a compression fraction of at least 60%.
What does that mean, compression fraction?
It means that for every minute the code is running, you should be actively compressing for at least 36 seconds of that minute. But really, our target should be much higher, closer at 80 or even 90%.
So no stopping to look at the monitor for 20 seconds or having a long discussion.
Never. Rhythm checks should be instantaneous. The next person should be hovering over the chest, ready to take over the second the first person gets tired. No delays.
Okay, before we move on to defibrillation, let's just quickly touch on ventilation in BLS. For an adult without an advanced airway, what's the magic ratio?
It's 30-2. 30 compressions followed by 2 breaths.
And how big should those breaths be?
Small, just enough to see the chest begin to rise. We're talking about 500 to 600 milliliters delivered over about 1 second.
Why not big breaths? I feel like the natural instinct would be to just jam as much air in there as possible.
This is another one of those deep dive insights you get from Miller. Overventilation is lethal.
Lethal, that sounds traumatic.
It's physiological fact.
Yeah.
If you bag the patient too fast or with too much volume, you massively increase the intrathoracic pressure. That pressure squeezes the great veins, the superior and inferior vena cava shed.
Oh, it acts like a tourniquet on venous return.
Precisely. So by trying to give more air, you're actually dropping cardiac output to 0. You can literally bag a patient to death during CPR. It's a critical exam point.
Okay, overventilation kills by decreasing venous return. Got it. Let's move down the chain now to link 3, defibrillation.
Right. So this is for the shockable rhythms. That's ventricular fibrillation, or VF, and pulseless ventricular tachycardia, or PVT.
And just to be absolutely clear for the students listening, what if the monitor shows asystole, or pulseless electrical activity, PEA?
Those are non-shockable. You do not shock a flatline. You continue high-quality CPR, and you give drugs. If you say in an exam that you would shock asystole, you might as well just get up and walk out of the room.
Harsh but true.
It shows a fundamental lack of understanding of cardiac electrophysiology. It's a major red flag for an examiner.
Okay, so for the shockable rhythms, we have 2 types of machines we might see. Monophasic and biphasic. What's the difference?
Monophasic is the older technology. It sends a current in one direction from one pad to the other. It requires more energy, usually 360 joules.
And biphasic?
Biphasic is smarter. It sends the current in one direction and then reverses it for the second phase of the shock. It's more efficient. It requires less energy, usually 120 to 200 joules, depending on the manufacturer, and it causes less myocardial damage or burn.
Right. Now, what about the stacking shocks question? I've definitely seen this in older textbooks. Do we still give 3 shocks in a row?
As a general rule, no. The current guideline is 1 shock, then immediately resume CPR. And this is another huge point. You do not check the pulse immediately after the shock.
Wait, really?
Hmm?
You shock them and you don't even check to see if it worked. That feels so counterintuitive.
It does, but here's the physiology behind it. Even if the shock was successful in terminating the VF and resetting the heart's electrical activity, the heart muscle itself is stunned. It's electrically organized, but mechanically silent.
So it's not pumping effectively yet.
Not at all. It needs a minute or 2 of good compressions to circulate oxygenated blood and generate the ATP it needs for an organized contraction. So the sequence is shock, followed immediately by 2 minutes of CPR, then you check the rhythm and the pulse.
Is there any exception to that single shock rule?
Yes, and this is a fantastic point to bring up in a Viva to show you've read Miller carefully. In a fully monitored setting, say, the cath lab or a cardiac ICU, if you witness the arrest happen right in front of you and you have the pads on the patient already.
So zero delay.
Zero delay. In that specific scenario, you can consider 3 stacked shocks. The logic is that the heart hasn't been ischemic yet, so you might just need to zap it back into a normal rhythm. But for a general ACLS scenario, you stick to the single shock strategy.
Got it. Okay, let's transition now. We've covered BLS. We've covered defibrillation. Now we're in the hospital. We have a full team. We have a crash cart. We're moving into ACLS, Advanced Cardiac Life Support.
Right. And the core of ACLS is organizing your team and your actions around 2-minute cycles. Everything happens in 2-minute loops.
Walk us through a typical cycle.
Okay. You're in the middle of doing high-quality CPR. The monitor is attached. After 2 minutes, you have a brief pause, less than 10 seconds, for a rhythm check. Is it VF or PVT?
Could say yes.
Yes. Okay. The person in charge calls for the defibrillator to be charged. While it's charging, compressions continue. Once it's charged, you clear the patient. I'm clear, you're clear, everybody's clear. You deliver the shock. And then what?
Immediately restart CPR.
Immediately restart CPR. Now, while those next 2 minutes of compressions are happening, you are working on other things. You're getting vascular access.
IV is standard, but what if you can't get a vein? In a collapsed patient, it can be tough.
Intraosseous, IO. If you can't get an IV in, say, 2 attempts or 90 seconds, you drill the bone. The humeral head or the proximal tibia are the common sites. It's faster. And drug delivery to the central circulation is just as quick as a central line in this scenario.
So we're doing CPR, we have access. When did the drugs go in?
During the CPR phase, you never, ever stop compressions to draw up or administer a drug. Someone on the team does that while the compressor's working.
Okay, let's talk about the drugs. This is an exam favorite. What is the king or queen of cardiac arrest drugs?
Adrenaline or epinephrine, depending on where you are.
Yes.
1 milligram, 5E or IO.
And the frequency?
Every 3 to 5 minutes. So basically that works out to every second 2-minute loop of the algorithm.
Now here's the critical why question. Why are we giving adrenaline? Is it to, jumpstart the heart with a jolt of energy?
That is the common misconception. Students often think it's all about the beta adrenergic effect, increasing heart rate and contractility. But in an arrest, the primary mechanism we're leveraging is its potent alpha-adrenergic effect.
The vasoconstriction.
Massive peripheral vasoconstriction. It clamps down the blood vessels in the arms, the legs, the skin, the gut, everywhere, not essential. This shunts all the available blood away from the periphery and directs it to the central circulation.
So it's a plumbing fix, essentially.
Mm-hmm.
We're trying to increase the pressure in the core pipes.
Exactly. You're trying to increase the aortic diastolic pressure. And why do we care so much about that? Because coronary perfusion pressure, the pressure that drives blood into the heart muscle itself, is determined by the difference between aortic diastolic pressure and right atrial pressure. By spiking that aortic pressure, you force blood into the coronaries.
So we are sacrificing the toe to save the heart and the brain.
Precisely. We're shunting flow where it matters most at the expense of everything else.
What about anti-arrhythmics? When do they come into play?
These are for refractory VF or PVT. That means the shock isn't working. You've given a shock, maybe 2, and they're still in that chaotic rhythm.
The first line drug here is Amiodarone.
And dose for that?
The first dose is a 300 milligram bolus. If that doesn't work and they're still in VF after the next shock, you can give a second smaller dose of 150 milligrams.
And if, for some reason, we don't have Amiodarone available, lidocaine is the alternative. The dose is 1 to 1.5 milligrams per kilogram, but Amiodarone is generally preferred because it works on multiple ion channels. Sodium, potassium, calcium. It's a sort of a broader weapon against that electrical chaos.
What about magnesium sulfate? I definitely remember learning about that in med school.
Magnesium is for a very specific situation. You only reach for it if you see torsinosity points on the ECG, that characteristic twisting rhythm, or if you have a very strong suspicion of hypomagnesemia, like in a chronic alcoholic or a severely malnourished patient. It is not for routine cardiac arrest.
Got it. And just to be completely clear for the exam, are we still using atropine or vasopressin in the standard pulseless arrest algorithm?
No, they are out. Atropine is for symptomatic bradycardia, a slow heart rate with a pulse. It has no role in asystole. And vasopressin was removed from the algorithm back in the 2015 updates because multiple studies showed it offered no survival benefit over adrenaline.
So for the exam, stick to adrenaline and amiodarone.
That's your safe answer, yes.
Yeah. Okay, let's talk about airway management during ACLS. We mentioned earlier that the compression to ventilation ratio changes. This is a critical pivot point in the exam answer.
It's a huge point. Initially, with a bag mask, you're doing 30 compressions, then pausing for 2 breaths. But as anesthesiologists, our job is often to secure that airway, usually with an endotracheal tube or a supraglottic airway like an iGel or an LMA.
Once that advanced airway is in place, what happens to the 30-to-2 ratio?
It disappears completely. You decouple the compressions and the breaths.
Decouple?
Yes, the person doing compressions just pushes continuously, 100 to 120 times a minute. No more pauses for breaths. At the same time, the person on the airway gives 1 breath every 6 seconds.
So that's 10 breaths a minute. Asynchronous.
Exactly. Asynchronous ventilation. 1 breath every 6 seconds. Continuous compressions.
And how do we know the tube is in the right place? The examiner is going to ask for confirmation methods.
You need to say waveform capnography. It is the gold standard for confirming and continuously monitoring ET tube placement.
Not just listening to the chest.
Listening to the chest is not reliable enough, especially in a noisy code situation. You want to see that square waveform on the monitor.
And capnography isn't just for placement, is it? It can tell us about the quality of our CPR.
This is a huge point to make, yes. The end-tidal CO2 or ETCO2 value is a direct correlate of cardiac output.
How does that work?
Well, think about it. CO2 is produced in the tissues, it's carried by the blood to the lungs, and then it's exhaled. If the pump isn't working, if your CPR is ineffective, then no blood is getting to the lungs, so no CO2 is exhaled. If your ETCO2 is less than 10 millimeters of mercury, your CPR is garbage.
So it's a real-time feedback tool.
Exactly. It tells you to push harder or deeper, or maybe to switch the person doing compressions because they're tired.
And what if the number jumps up suddenly?
If you're compressing along with an ETCO2 of, say, 15, and it suddenly jumps to 35 or 40, that is often the very first sign of ROSC. The heart has started pumping on its own, flushing all that accumulated CO2 out to the lungs. It's a beautiful sight.
That's a great segue. So we're doing high-quality CPR, we're giving the right drugs, we're shocking when we need to.
Yeah.
But you always say, while you compress, you must think.
You must. You cannot fix the arrest if you don't fix the underlying cause. If the patient has bled out onto the floor, no amount of chest compression is going to refill their vascular volume. This is where we use the mnemonic of the H's and T's.
The reversible causes, let's run through them. Let's start with the H's.
First, hypoxia, a really common one for us. Is the tube blocked? Is the oxygen disconnected? Is the ET tube in the esophagus? You have to fix the oxygenation.
Okay.
Second, hypovolemia. Look for a history of trauma, GI bleeding, or severe dehydration. If the neck veins are flat, you need to be pushing fluids or blood.
Third H.
Hydrogen ion acidosis. This almost always builds up during a prolonged arrest, but if they were severely acidotic beforehand, like in DKA or a toxic ingestion, you might need to think about bicarbonate or hyperventilation.
Yep.
Hypo or hyperkalemia. This is huge, especially in patients with renal failure. If you saw peaked T waves on the pre-arrest ECG, you should be giving calcium gluconate to stabilize the heart membrane.
And the last H.
Hypothermia. You can't pronounce someone dead until they are warm and dead. You have to actively rewarm them.
Okay, now for the T's.
First T, tension pneumothorax. This is a big one for us in anesthesia and ICU. If a patient on a ventilator suddenly arrests, this should be very high on your list of differentials.
And the fix is immediate decompression.
A needle or a finger in the chest. Now,
Next T.
tamponade, cardiac, blood in the sac around the heart. You might see a narrow pulse pressure before the arrest, or even better, you put an ultrasound probe on the chest. If you see fluid squashing the heart, it needs to be drained with pericardiocentesis.
Okay.
Then toxins, did they overdose on something? Opioids, give naloxone, local anesthetic, systemic toxicity, give intralipid.
And the last 2 T's are the big clots.
The big clots, thrombosis, pulmonary, a massive PE, and thrombosis coronary, a massive MI.
So in the exam, drawing a simple 2-column table of the H's and T's and briefly mentioning the specific treatment for each is a great way to score easy marks.
Absolutely. It shows the examiner you are thinking like a clinician, not just a robot who has memorized an algorithm.
Okay, let's say we succeed. We've treated a reversible cause, we see that spike in ETCO2, we pause compressions, and we feel a strong, regular pulse. We have ROSC. Are we done? Do we high-five and go for T?
No, absolutely not. Now the hard work really starts. This is section 9 in your long answer, post-cardiac arrest care.
What are the immediate priorities here?
Stabilization, first. Hemodynamics. The heart is weak. It's been stunned by the arrest and the electricity. You need to support the blood pressure. The goal is typically a systolic BP greater than 100 or a mean arterial pressure and MAP greater than 65.
And if it's low, we might need vasopressors.
Almost certainly. You'll likely need an infusion of something like noradrenaline or maybe dobutamine to maintain that perfusion to the brain and other organs.
Okay, what about oxygen? We were blasting them with 100% during the arrest. Do we just keep that going?
No. This is another major exam point. Once you have a pulse back and you have a reliable saturation reading, you titrate the oxygen down. The target's SpO2 is 94 to 98%.
Why not 100%? Again, it feels counterintuitive. Isn't more oxygen always better?
Not in the post-arrest brain. Hyperoxia, too much oxygen, causes oxidative stress. It generates free radicals that can cause further damage to the neurons that have just suffered a major ischemic insult. It's part of what we call reperfusion injury.
So Miller is clear on this.
Very clear. Avoid hyperoxia. It actively harms the neurons you just worked so hard to save.
And what about temperature? I remember we used to hear a lot about therapeutic hypothermia.
The terminology has shifted a bit. We now call it targeted temperature management, or TTM. The main idea is to prevent fever at all costs. Fever is like pouring gasoline on a fire in the injured brain.
So we cool them down.
You might select a target temperature anywhere between 32 and 36 degrees Celsius for a comatose patient to protect the brain. But the absolute key is just avoiding hyperthermia.
And obviously, if the arrest was caused by a massive heart attack, they need to go to the cath lab.
Immediately. If there's any sign of ST elevation on the post-ROSC 12-lead ECG, the cardiology team should be activated for an urgent coronary angiogram.
Let's briefly touch on a couple of special considerations. The exam often likes to throw a curveball. A big one is resuscitation in pregnancy.
A very high-stress, high-stakes scenario. The physiology is completely different. The gravid uterus, especially in the third trimester, is big and heavy. It compresses the inferior vena cava and the aorta when the mother is lying flat on her back.
Which means your chest compressions won't work very well.
They'll be almost completely ineffective because there is no venous return. The IVC is squashed flat. So the single most important intervention is manual left uterine displacement. Someone on the team has to physically get their hands on the abdomen and push the entire uterus to the left to get it off those big vessels.
And if that doesn't work and you don't get ROSC?
Then you have to move to the perimortem cesarean delivery. The rule is if there is no ROSC within 4 minutes of starting resuscitation, you deliver the baby.
Primarily to save the baby.
Primarily to save the mother, actually. It's a resuscitative hysterotomy. Emptying the uterus massively improves maternal hemodynamics by relieving that aortocaudal compression. But of course, it gives the baby its only chance of survival, too.
What's the timing on that?
The mantra is, start the cut at minute 4, deliver the baby by minute 5.
That is incredibly intense. What about in our home environment, the ICU or the operating theater? We have a lot more monitoring there.
If you have an arterial line in place, use it. You don't need to waste time palpating a femoral pulse during a rhythm check. Look at the waveform on the monitor. More importantly, look at the diastolic pressure during compressions. If your arterial diastolic pressure is less than 20 millimeters of mercury, you are not pushing hard enough.
So it's a real-time CPR quality monitor.
The best one you have.
Okay, we are nearing the end. Let's do a quick Viva trap segment. What are the common things that students say that just make examiners groan?
Trap number 1, I'll give intracardiac adrenaline. No, just no. We do not do that like in the movies. It's IV or IO. Sticking a needle blindly into the heart usually hits a coronary artery and causes a fatal tamponade.
Okay, good to know. Trap 2.
Checking the pulse immediately after delivering a shock. We've covered this, but it bears repeating. Don't do it. Shock, then 2 minutes of CPR, then check.
Trap 3.
Stopping compressions for more than 10 seconds to intubate. The intubation should happen during compressions if you're skilled, or with an absolute maximum pause of 10 seconds. If you can't get the tube in that time, use a bag mask or an LMA. Do not sacrifice perfusion for a plastic tube.
And a final trap.
Confusing the definitions.
Yep.
Knowing the absolute difference between a shockable and a non-shockable rhythm, if you tell an examiner you would shock asystole, you are demonstrating that you are dangerous and you will fail. It's that simple.
Brutal, but necessary. Okay, let's wrap this all up. I'm sitting in that exam hall. I'm sketching out my 20-mark answer on the back of the question paper. What does the ideal structure look like?
Simple. 1, start with your definitions. Cardiac arrest and the goal of CPCR. 2, the chain of survival. Draw the 5 links.
Okay.
3. The BLS algorithm. Draw the simple box and arrow flowchart. Emphasize CAB. And list the metrics for high-quality compressions. Rate 100, 120, depth 5-6 centimeters, full recoil.
Right.
4. Defibrillation. Briefly mention monophasic versus biphasic. 5. ACLS. Mention the key drugs: adrenaline 1 milligram, amiodarone 300 milligrams. And crucially, mention the change in the ventilation ratio after an advanced airway is placed.
And the reversible causes.
Yes. 6. The H's and T's. Draw the 2-column table. And finally, 7. A short section on post-arrest care, focusing on the oxygenation targets and hemodynamic goals.
Perfect. It's systematic, it's evidence-based, and it covers the why, not just the how.
Exactly. That's what separates a passing answer from a great one.
Before we sign off, leave us with a final provocative thought. Where is this entire field going in the future?
Well, if you look at the cutting edge, what we're seeing in major centers is the rise of eCPR, that's extracorporeal CPR.
Using an ECMO machine during the arrest itself.
Exactly, putting the patient on heart-lung bypass during the arrest. And at the same time, we're seeing the increasing use of mechanical compression devices, like the LUCAS machine. It really raises the question, in a well-resourced tertiary center, are manual chest compressions becoming obsolete? Can a human being ever compress as perfectly and as tirelessly as a machine? It's something to watch for in the next edition of Miller.
That is fascinating stuff. Okay, everyone, visualize that algorithm one last time. CAB, push hard, push fast, minimize interruptions. You've got this. Good luck with the exam.
Good luck.
See you next time on The Deep Dive.